Hi, my name is Angela Orozco. I'm here to present to you my patient. This is a 50-year-old male who was brought to the emergency department with shortness of breath, chest pain, nausea, and vomiting. The onset of his symptoms began 3 days prior to admission. Prior to his visit to the emergency department, he was discharged from the hospital 3 days ago, in which he was hospitalized with stab wounds, and he was discharged home. He said that his symptoms have currently been progressing and worsening. His pain is he rates it from a 5 to a 7 out of 10. He says it's a dull ache. He is taking over-the-counter pain medication, ibuprofen, 800. By mouth, he says he's unrelieved. His pain is unrelieved, and he has no bloody emesis, no bloody stools. His medical history consists of hepatitis C. He had multiple stab wounds, and this was requiring a hospitalization in February up until March of 2015. His surgical history included, which was in February 2015, is multiple X-laps. He had a left adrenalectomy, a splenectomy, a left diaphragm repair, a left thoracotomy for a left ventricle laceration that was repaired, a left lower lobe laceration as well. His social history includes IV drug abuse. He states he uses heroin. The last time he used it was yesterday. His family history includes his mother with diabetes. He had multiple transfusions during his stay in February. He has no allergies to any medications. So he reports fevers, chills, weakness, chest pain, and abdominal pain. He has no sore throat, no nasal congestions. He has shortness of breath, cough, no hemoptysis. He has chest pain with inspiration, no palpitations, nausea, vomiting, no diarrhea, no constipation, no rectal bleeding, no dysuria, no hematuria, no discharge. Musculoskeletal, he has no joint pain, and he has no bone pain. He's a GCS 15. He's moving all extremities. He is cooperative and appears withdrawn. His laboratories include white blood count of 15.76, red blood count of 3.29, hemoglobin of 9.2, hematocrit of 27.3, platelets of 560, sodium of 135, potassium 3.7, chloride 98, CO2 28, blood sugar is 102, BUN is 14, creatinine is 0.32, iron is calcium 1.24, magnesium 1.4, phosphorus 4, total bilirubin 0.7, HIV negative. The EKG was done. It showed just sinus tachycardia. A chest x-ray was done now, and the chest x-ray shows bilateral opacities, more so on the left lower lobe. Upon physical exam, this is a 50-year-old male. He appears in mild distress. He is emaciated. He's pale in color. He's awake, alert, oriented to person, place, and time. His vital signs include 38.0 of oral temperature, blood pressure 107/65, heart rate is 137 beats per minute, respiratory rate is 36. He is on room air. He's starting 91%. His head is normocephalic. There's no lacerations, no edema. Pupils are equal, round, and reactive. They're about 3 millimeters in size, equal bilaterally. Extraocular movements are intact. Tympanic membranes are intact bilaterally. There's no rhinorrhea, no otorrhea. Neck is with no masses, no edema, no JVD. Trachea is midline. There's no retractions, no bruits, auscultated. There is bronchi to all lung fields. There's no wheezing, no retractions. Patient with mild shortness of breath, slight tachypnea, no stridor. His spine appears midline. There's no pain upon palpation. S1, S2 auscultated, sinus tachy to the monitor. No murmurs, no gallops, pulses are 2 peripheral and central locations. Equal chest expansion is noted. There's no discharge, no dimpling, no use of accessory muscles. Abdomen is soft. There's scars noted to the abdomen. No dilated veins, no masses, no bulging, no hernias, no pulsations. Active Balsams to all quadrants negative. Source sign, obturator sign, and Ralston sign are all negative. Negative Murphy sign. Genitals with no discharge, no lesions, no masses. Extremities are with no edema. They're equal movement. Reflexes are 2 to patellar, tricep, and bicep. They're +2, equal, bilateral. There's no clubbing to the extremities, and pulses are equal. Upon neuro exam, like I said, he's a little withdrawn. He's a GCS 15. He moves all extremities. Cranial nerves 2 through 12 are intact. Patient is cooperative. Scattered scars and old bruises. Clinical impressions: SIRS, dyspnea, fever, pneumonia, chest pain. Assessment plan: dyspnea. We're going to place on the oxygen nasal cannula. T% greater than 93%. We're going to do an ABG stat. We're going to do some nib treatments ×1. Albuterol 90 mics per puff. 2 puffs every 4 hours as needed. We're going to follow up on the chest X-ray. We're going to, for his chest pain, we're going to give him some morphine. 2 milligrams IV ×1 stat. We're going to do a CT angio of the chest with contrast. We're going to do troponins. We're going to do CKMB. For possible SIRS, we're going to take a lactate level, give him 500 NS bolus, IV ×1, see what how he responds to that for his heart rate. For rule out of pneumonia, we're going to send cultures, and we're going to start him on Levaquin 750 IV, infuse over 90 minutes, and we'll give this once a day. We're going to do CPT, and we're going to give him neb treatments every 4 hours. For his abdominal pain, we're going to go ahead and do a CT abdomen of the pelvis. We'll take a lipase level, a KUB. For the fever, we're going to pan culture, send blood culture, send urine, do a complete urine UA. We're going to send stool for C. diff and start antibiotics after culture sent. For pain control, we're going to give him morphine, 4 milligrams IV every 2 hours, IV, PRN. For DVT prophylaxis, we're going to give Lovenox 30 milligrams BID subcutaneous. We're going to put SADs to bilateral lower extremity, and we're going to admit to ICU. Some differential diagnoses to consider are flumilant sepsis syndrome, asplenic sepsis, pneumonia, urinary tract infection, SIRS, septicemia, pulmonary embolism, peritonitis, obstruction, pain, anxiety, or acute MI. Thank you for your time. Have a good day.